Great. Hi, everyone. It's great to see such a good turnout. I want to acknowledge with respect that we're gathered here today on the stolen, continually occupied lands of the Lekwungen peoples, specifically the Sami, Siswaimal, and Musang First Nations. This is an event that is being put on by the University of Victoria, which sits on the lands of those nations. And we just acknowledge and respect that these nations have a continual relationship to this land. And today we are here to talk specifically about drug policy and the toxic drug supply emergency in North America. And so we acknowledge the deeply racist roots of drug policy as we go about thinking on these matters. I'm very excited to be able to introduce our guest, Dr. Leo Beletsky, who is here from Boston. He is a professor at Northeastern University in Boston, and he has a joint appointment in the School of Law and the College of Health Sciences there. One of the reasons that we were really interested in the head speaker in speaking with Leo this week is because of that joint expertise in law and public health. So Leo's expertise is on the public health impact of laws and how they're enforced, with a special focus on substance use and addiction, infectious disease, occupational safety of first responders, and policing as a structural determinant of health, which I know is also of interest to many folks here and online. With that, hand it over to Professor Beletsky.
Thank you so much. Thanks, Karen, and thanks to all of you for joining. It's really a pleasure to be here and to be able to speak with all of you. The topic of my talk is very broad, and so I'm not going to be able to kind of hit on all of the different elements and dimensions of this crisis. But I do hope that by leaving about half an hour for discussions and the Q&A at the end, we can kind of drill down to some of the broader elements of the crisis that I will, maybe only touch on. So I really have appreciated the opportunity to be here at UVic and speak with folks at the CoLab and CSER and try to understand some of the similarities and contrasts between the crisis as it exists in the United States and the crisis as it exists here in Canada. So today I'll be talking about the US side of the coin, and I think it does have implications for the response here in Canada as well, because whether you want it or not, a lot of the sort of the narratives and tropes that permeate the way that we talk about the crisis in the United States does sort of travel up north and does inform some of the policy debates here. And I think that could be some of the sort of debunking and talking about misinformation and sort of the narrative that we have developed around the crisis in the United States may be informative for how we formulate policies and the way that we rationalize responses in Canada as well. So first, I wanted to kind of problematize the very idea that this is an opioid epidemic. So as I'll talk about, language is really important. The way that we talk about issues is really important. And the very moniker, though, opioid epidemic is inaccurate and problematic. Then I'll talk about sort of how deploying policies in response to the crisis based on this misunderstanding of what the crisis is has actually made it worse. And then think about if we were to rethink the way that we understand what the crisis is and how we respond to it might actually help to address it and ameliorate it going forward. So as a first note, wanted to just mention that language is really, really critical in public health policy, because in many ways, the way that we frame a problem informs how we think about responding to a problem. And there's actually, it's not just sort of woke language policing. There's a lot of evidence that suggests that the way that we frame issues, like, for example, calling someone an addict, or using the term substance abuse, actually changes the way that people receive services. So there's been a growing base of evidence that suggests that even using certain language in charts of patients can change the way that providers deploy interventions, and certain kinds of words, like the words abuse, for example, elicit more punitive, more coercive responses from providers. And this also applies to the public policy realm, as well as I'll talk about. And this is somewhat of a new thing that I'm doing, although I know it's not new technology, but I'm providing QR codes on some of the slides that are linked to URLs, to web pages, or to articles that provide more information about the topic that the slide is on. So if you're interested in learning more, QR codes are provided to allow for that. So the way that the US overdose crisis, or the opioid epidemic, has unfolded has sort of the trajectory can be divided into 3 and maybe now 4 waves. The first wave is really what folks call the prescription drug or the painkiller epidemic, or the painkiller crisis. And that the accepted wisdom is that it started around the turn of the 21st century and unfolded for about a decade. Followed by the second wave, which was characterized by a leveling off in the deaths involving opioid analgesics, and the rise in deaths involving heroin. Followed by the third wave, which involved the steep rise in overdoses involving fentanyl and other synthetic opioids. So this idea that there's been kind of this 3-phase, like a play in 3 acts, if you will, is something that has sort of gained attention and gained recognition in the United States. And now folks are talking about the 4th wave of the crisis, which is the combination of the opioid and the stimulant crisis, which is now currently unfolding with the rise in overdoses involving methamphetamine specifically, but also cocaine. So how did this crisis, why did this trajectory take place? Why did the crisis morph in this way? And if you use the kind of the framing of the epidemic, in a way, you can think about it as we saw with COVID, the sort of the morphing and the mutation of an infectious disease crisis that keeps changing based on what kinds of interventions you're deploying to address it. So the accepted wisdom about how this crisis unfolded is really sort of it's been reduced or Hollywoodized, and I did contact my friend ChatGPT to see if this was a word, and it turns out it is a term. So we've sort of created this narrative that this crisis is really about sort of the villains and the heroes, where the villains were big pharma and unscrupulous doctors, sort of other actors in the pharmaceutical industry, hoodwinking people into taking opioid drugs. And then once they took these drugs, they were sort of gripped by addiction, and they, their brains were hijacked, and they started kind of sliding off the rails. and the regulators were essentially looking the other way as this all was unfolding, or maybe their hands were tied. You know, the prescription drugs, so OxyContin and the deployment of fentanyl patches and other kinds of opioids was sort of this almost conspiratorial situation that took place. The pill mills that were kind of flooding communities were partly responsible for it as well. The good guys in that story, and you know, this has now been dramatized repeatedly in various scripted TV and movie adaptations of this storyline, were you know, dedicated law enforcement agents who were out there, you know, fighting against this kind of trying to, you know, put their hands on this flood of opioids poisoning their communities. And you know, I'm using the language kind of, I don't want to keep doing air quotes here. So you know, this is a language that gets deployed, a lot of maritime metaphors, you know, tides and flooding and other kinds of imagery to communicate just the vast amounts of opioids that were moving into various communities. That, you know, there were sort of active attempts by politicians to do something about the crisis, but it was just too powerful for them to address it. And then also the storyline includes litigation, so opioids, lawsuits against opioid manufacturers, distributors, and so forth, and the securement of the opioid settlement funds, which are thought to remedy some of the problems that were created by this problem. So this reductionist view is really problematic because it really obscures the true nature of the crisis. And because of this language, the opioid epidemic, the responses that were deployed to address the crisis in the first decade of the 21st century made the crisis worse. They basically, these responses in many ways poured fuel on the fire, and the crisis morphed and became even deadlier and more problematic, and it continues to gather steam to this day because we're not addressing it, we're not diagnosing it correctly, and therefore the responses that we're deploying are not effective and sometimes counterproductive. The sort of the key data point that informed the early responses to the crisis have to do with the collinearity between the availability of opioid analgesics and overdose deaths involving prescription drugs during the first decade of the 21st century. And there's no question that this collinearity had some causal connections and that folks were indeed dying of overdose because they were taking opioid analgesics. But the causal connection and the causal relationship is not as simple as it's being described, as I'll talk about. And based on the misunderstanding of that sort of relationship, the policies and other structural interventions that were deployed missed the mark. So I want to talk a little bit about the moniker, the opioid epidemic, because in many ways, I think it encapsulates this misunderstanding, this misdiagnosis of what the crisis actually was. The common thinking about how the prescription drug crisis affected overdoses really goes back to the understanding of sort of a role of a greedy, corrupt actors within the pharmaceutical industry who created the idea that pain should be the fifth vital sign, that we should be asking patients about levels of pain. And because there were no sort of biomarkers, no way of validating what people were saying their pain levels were, this led to kind of a lot of patients misrepresenting their levels of pain, or maybe being mistaken about what they were feeling. That's the sort of the common wisdom, and it opened an opportunity for people to overutilize opioids or to divert opioids, and sort of created this fertile ground for overprescribing. At the same time, this common narrative goes that there were pill mills open throughout the United States that were just again flooding communities with these dangerous drugs, getting people hooked, and then just kind of using these patients to generate more and more money. The implication of this framing, this idea that opioids became kind of a vector, like a contagion throughout the United States, is kind of going back to the main facets of public health, is that if you have a vector, if you have a disease vector, then trying to address this vector, like we have with COVID, through sort of vector control, quarantine, vaccines, that vector control was going to be an effective response to an epidemic, right? If you use the word epidemic, then you kind of are thinking, well, opioids, these opioid painkillers are the problem. If we stop the flow of these opioids, we will address the problem. Part of this narrative also pivoted on the idea that U.S. overutilizes opioid medications compared to many times over compared to their peer countries. So a lot of folks who were proponents of sort of the supply control narrative, that we needed to control the supply, said, well, how come the U.S. overutilizes opioids compared to their peer countries? We need to, if they can have a normally functioning society without so many opioids, then maybe we can too. Even compared to sort of US's most sort of comparable society, the United Kingdom, the picture actually doesn't look quite as drastic, but certainly the US is a much more active consumer of opioids. I think it's important to acknowledge that in this context, the fact that US overutilizes opioids in the kind of the global arena is something that is needs to be understood in relationship to the fact that US overutilizes a lot of different products. Probably overutilizes meat per capita. It overutilizes the I don't know, straws and all kinds of other gasoline, square footage in houses, and also it's important to acknowledge that on a global arena, opioids are vastly underutilized. So thinking about the fact that opioids are widely available in the United States has to be understood in the context of the fact that they're not widely available in many other places. So for example, methadone, an essential medicine that is used to treat opioid use disorder, is not available in a number of different countries for that purpose, including Mexico, Russia, now parts of Ukraine, and many other places. So we need to understand that this overutilization has to be seen in that global context as well. So because there was this understanding of the epidemic model of the crisis, there was also that led to a conceptualization of interventions that were vector control interventions. This included a bunch of efforts to suppress opioid prescribing, the development of prescription drug monitoring systems, which are government databases that surveil the prescribing, dispensation of various controlled substances. It led to a lot of enforcement actions to shut down what are called pill mills. In some cases, these were actually, sort of bad actors. In some cases, these were just prescribers working in highly vulnerable communities where there was not a lot of healthcare resources available. And it also led to the suppression of what prescribers were taught to do, which is to ask people about their pain levels. So the idea is like, if you don't ask people about, how much pain they're in, then we're not gonna overprescribe opioids, which is, kind of a strange intervention, but nonetheless, that was the thinking. And then it also led to, or kind of paved the way to the conceptualization that people with opioid use disorder, people with addiction, needed to be isolated or institutionalized in the same way that we have quarantine for, infectious disease. There's an open door when you have this kind of vector framing to understanding of substance use and addiction as a reason to institutionalize people. So it led to, as I'll talk about, the increased support for involuntary commitment and sort of residential treatment and other ways of isolating people who take opioids. Just to illustrate this sort of deployment of vector control measures, here's a graph showing the broad sort of push to expand and develop new prescription drug monitoring programs. So again, these are government databases that are sort of conceptualized by law enforcement, but sort of exist at the intersection of law enforcement and healthcare systems, where controlled substance prescriptions are tracked and documented, as well as the dispensation of controlled substances. And the development and the deployment of prescription drug monitoring systems really is an illustration of how the lines between law enforcement and healthcare practice became blurred during this kind of response. Because what it did is it really enlisted prescribers in policing the prescription and dispensation of controlled substances. So it really created this sort of role merging of the roles of prescribers as not just care providers, but also agents of sort of policing how people were taking drugs and, sort of dinging people for doctor shopping, quote unquote, or possible diversion activities. And when we did some research on the how prescriber practices changed in response to being monitored through these databases, essentially a lot of prescribers talked about increased practice of cover your ass medicine. Basically the idea that if people were looking over your shoulder all the time, that you would prescribe differently, and this in fact took place. So it wasn't just that prescribers were being prosecuted or the professional medical boards were going after people for possibly overprescribing or engaging in illegal practices. It was also that the perception of prescribers really changed. So instead of thinking about the prescriber-patient relationship, they were thinking about a third party, which is law enforcement basically looking over their shoulder. So these efforts to reduce prescribing, to kind of turn off the faucet of opioids going into American communities worked. Because the levels of prescribing that had been rising up till around 2009, 2010 started to decrease. And they decreased for many years, including right now, they're back to levels of the early 90s. Unfortunately, that success was actually a failure because the collinearity between prescribing and overdoses started to become actually an inverse relationship. So the more prescribing decreased, the more overdoses started to skyrocket. And this really kind of is the pivot in the story between the first wave of the crisis that had to do with opioid analgesics and the second wave of the crisis that had to do with the rise in heroin-involved deaths. Because what actually occurred was that people's demand for opioids, not talking about supply now, talking about the demand for opioids, really did not decrease when the pills dried up. The demand stayed very strong. And when the availability of safe supply through the prescription channels, whether the drugs were available through prescribers or maybe they were diverted, when that started to dry up, people started to go to the illicit market where they were widely available. So, the sort of the regulation of the illicit market, the control by the Drug Enforcement Administration really hadn't been effective in the sense that there was wide availability of both counterfeit pills as well as heroin on the illicit market in the United States. And so the folks who had been taking prescription medications, whether they were addicted actually, or maybe they were just dependent and were using it for chronic pain or substance use treatment, they started to procure those opioids on the illicit market. At the same time, you had the rise of the dark web and cell technology that really transformed how people were able to access the illicit market, and that facilitated the transition as well. And unfortunately, instead of seeing the decreased prescribing and decreased availability of prescription opioids, you saw a rise in deaths, as I already mentioned. The sort of the transition to the illicit market also underscored the fact that the term opioid epidemic really was a moniker that was inaccurate on both points. It was not actually an epidemic in the sense that suppressing supply, suppressing the vector did not address the problem, but it also really wasn't about just opioids. The overdoses that we were seeing even in those early years of the crisis involved oftentimes many substances, as they do now. Folks were overdosing oftentimes on a combination of opioids and alcohol, opioids and benzodiazepines. There are also opioids involving stimulants, as there are now, although now certainly we have more of them. And this continues to the present day, where xylazine is now on the scene. But even back then, many deaths involved a combination. It was really a polysubstance poisoning crisis. At the same time, as I already mentioned, there was this the framing, the epidemic framing, gave a lot of momentum to the idea that people with addiction or people who use opioids, people who use drugs, really needed to be institutionalized. And it really gave a lot of support to various efforts involving institutionalization, such as involuntary commitment for substance use. So Massachusetts is actually, in the United States, is the sort of dubious leader in that respect. So Massachusetts involuntarily commits thousands of people a year, like 4, 5, up to probably 8,000 or 9,000 people a year, for a median of 22 days, but the law actually authorizes involuntary commitment for up to 90 days. And this is done through a very sort of ineffective judicial review process where most commitments are simply rubber stamped and people go into prison-like conditions to receive essentially abstinence-based care. Thankfully, that's changing now, finally, but typically, people are housed in Department of Correction facilities and do not receive medications and simply, sort of go into precipitated withdrawal. Oops. And perhaps most tragically, the part of the story is that as the crisis shifted to the illicit drug supply, the availability of medications for opioid use disorder really did not increase in proportion. And this was largely because of the, sort of the opioid epidemic framing that I keep referring to, since this story of the crisis, the story of the epidemic involves corrupt pharma and misguided doctors prescribing opioids indiscriminately. It made it really difficult to advocate and convince people that they should turn around and now let doctors prescribe a different opioid to treat the problem that originated with pharmaceuticals in the first place. There's a cognitive dissonance in the storyline between the idea that the healthcare system sort of got all these people hooked, and now the healthcare system is also the answer, where a different kind of opioid is going to be prescribed to treat the same problem that they created. And so that resulted in a situation where, for example, these data are probably the biggest indictment of availability of medications for opioid use disorder in the United States, because what this team from Boston Medical Center did is they tracked people who experienced a non-fatal overdose to see if people who experienced a non-fatal overdose and had contact with the healthcare system would then be put on medications, because we know that non-fatal overdose is a huge predictor of future fatal overdose, right? And so you would think people who experience a non-fatal overdose would be, medications would be made available to them. They would take up these medications and then become much less likely to overdose fatally in the future. Sadly, when we look at this kind of index overdose event, we see, yes, there's a small uptick in people being on medication, but it's very, very minor. So, we go from around 12% to around 14% who experience a non-fatal overdose, then having access to buprenorphine, methadone, or naltrexone, we can kind of write off because it's not even clear that it provides any overdose protection, post the 30-day period. So this is just one illustration of just how harmful this idea that the healthcare system is at fault is to the protection of people who are at high risk of overdose from experiencing a future overdose. At the same time, just as the number of overdoses involving heroin and other drugs available on the illicit market, the response to that, the policy response, it was that politicians and other decision makers woke up to the idea, well, folks are now transitioning from the prescription drug supply to illicit drug supply. So based on this vector model, let's suppress the illicit drug supply. Let's double down on supply suppression methods. And this included a number of different interventions, including increased crop eradication efforts abroad, a huge increase in border detection and control measures to quote unquote stop the flow of illicit drugs into the United States. And all of these efforts really kind of mimicked the era, and not to say that they weren't already happening, but the major increase, the major uptick in these supply control measures on the illicit market, efforts to dismantle quote unquote drug trafficking organizations, mirrored some of the efforts that occurred during the alcohol prohibition era, when efforts to suppress the supply, to kind of close the faucet of illicit alcohol flowing from Canada and Mexico into the United States, shifted the supply of alcohol from what people were preferring at that time in the United States, which is beer and wine, which is what most people drank prior to prohibition, to gin, vodka, moonshine, and other spirits, which is why when you go to a bar, a lot of times mixologists wear like 1920s sort of fashion. That's not an accident. Like, alcohol cocktail culture really developed during that time because people shifted their preferences to spirits. So the iron law of prohibition, and maybe it's not so iron because there's some sort of exceptions to that rule, but generally the logic goes that attacking the supply creates an economic incentive for drug trafficking organizations to get more bang for their buck by doing ever smaller, ever more potent, more distilled, more concentrated production, and trying to maximize the return on their investment and the risk that they're taking. That's exactly what happened. So that's when we look at the rise of fentanyl-involved deaths, which is really stratospheric. It was a huge morphing and worsening of the crisis that occurred around 2015 to 2017 in the United States, where there's just this major shift in the supply towards synthetic drugs. That synthetic opioids do not require the planting of the crops. You're not dealing with crop eradication. You're not dealing with climate-related issues. You're not dealing with agricultural workers. You can produce much more at a much lesser price. And importantly, if there's increased pressure at the border, you can get more drugs through those sort of holes in your truck or whatever the vehicle is for transportation of drugs across a border. You're getting much more bang for your buck. And so the third wave of the crisis, the rise in overdoses involving synthetics, is in many ways the result of policy responses that preceded it in the first and second wave. So the increase in overdoses involving fentanyl and the rise of fentanyl sort of triggered a whole barrage of misinformation and panic. And so, drug misinformation is really not new. It's not, you think about sort of reefer madness and how the US drug control agencies from very early days tried to affect public imagination with scare tactics and misinformation, and maybe even disinformation about drugs, and the idea that cannabis was going to lead to destruction of the moral fabric of society, and that cocaine, myths about crack cocaine and crack babies, and the list goes on and on. The idea that LSD was is going to make you jump off buildings. So misinformation about drugs is really has been a province of US drug control policy for a long time. And the same was the case with fentanyl as well. Fentanyl became like the boogeyman of the overdose crisis. So there's a number of different myths, from Rayville fentanyl being found in Halloween candy to the idea that law enforcement can overdose by touching fentanyl. We've actually done some research to understand sort of the penetration of this misinformation in social and mainstream media. And what we found was that misinformation, so the idea, the construct that you can overdose by touching fentanyl, receives about 15 times more visibility than corrective narratives. So there are corrective news stories that try to sort of address this myth. But when you look at the sort of the permeation of that information in the infosphere, it doesn't receive nearly the same attention. In terms of like Facebook shares or other kinds of metrics. Fentanyl panic, this idea that fentanyl, has these magic properties, is something that really spurred a much more punitive response, and in many ways reversion to the war on drugs tactics. So around 2012 to 2015, you do see kind of a return to a much more law enforcement focused response to the crisis. And it really hadn't stopped, but at least the rhetoric had changed. There was a lot of discussion about the fact that we can't arrest our way out of this crisis, that this crisis requires a public health approach, but the rise of fentanyl really put a damper on even that rhetoric. There's a lot of now conversation about sending a signal to fentanyl dealers that this really was not going to fly, and that we were going to, law enforcement was going to come after them and sort of close the sort of the holes in the dike and stop the flow of fentanyl through building a border wall, various kinds of very hyper punitive mandatory minimums, and other kinds of law enforcement interventions. So one of the problems there are many problems with this kind of response, including what I already mentioned, sort of the iron law of prohibition, which is more pressure you put on the illicit drug supply, the more toxic the drug supply gets. But some of the other ones is that this kind of signaling of hyper punitive responses flies at sort of works at cross purposes with public health minded policies. So when on the one hand we have 911 Good Samaritan policies that encourage people to call for help during an overdose event, and we say, listen, we're going to essentially provide amnesty from drug-related charges for folks who call for help, or the victim or the person who's overdosing, just call. Don't need to worry about legal repercussions on the one hand, and on the other hand, you have law enforcement doing press conferences about how they're seeking 20-year mandatory minimums for people who share drugs with someone who overdosed. It really dampens and maybe negates the positive effect of Good Samaritan policies. So this effort to kind of create the signal that distribution of drugs was going to receive a hyper-punitive response really caught on during that time. And so you saw a proliferation of drug-induced homicide laws. So these are laws basically creating special penalties for people who distribute drugs to someone who overdoses. So they take an accidental overdose and make it almost intentional. They say, "Oh, this is a homicide. This is a murder." And so tracking the number of these prosecutions, you see that essentially the number of prosecutions starts to skyrocket in concert with the rise in fentanyl-related deaths. So, the idea that this kind of approach, this drug-induced homicide, these drug-induced homicide prosecutions and laws is really couched in this idea that this is an overdose prevention strategy. We have a rise in overdoses. We're going to address this by passing policies and deploying these policies against people who distribute drugs, and therefore the overdoses will decrease. It is not surprising that the way these kinds of prosecutions are deployed maps out onto disparities, racial disparities that existed during the war on drugs. So you see, for example, that folks who are Black and brown receive substantially higher sentences for the same crimes as white defendants. And as I already mentioned, there's this these policies that are flying across purposes to efforts to get people to contact help during an overdose event. And it's important to note that because the law enforcement response is deployed in a way that burdens Black and brown people more actively, then the impact of these this punitive response is going to be seen more acutely in Black and brown communities, which is to say that the disparities in the criminal legal system and the way that the criminal legal system is deployed against racialized populations is going to then translate into health disparities. And that's exactly what we've seen. We've seen the rise in overdose deaths is more accelerated in Native and Black and brown communities than in white communities, partly because of the impacts of the criminal legal response. So we know that the deployment of law enforcement interdiction efforts also is associated with higher overdose rates. So there's been a number of different studies looking at how on the neighborhood level, as well as on the national level, when you have more aggressive law enforcement interdiction efforts, drug busts, it creates kind of destabilizes the drug market and then leads to more overdoses down the line. This is a more recent article on the same topic from the United States. And we also know that deploying these kinds of punitive responses has other ways in which it aggravates overdoses rather than reducing them. So even though the sort of law enforcement interdiction efforts are done under the banner of overdose prevention, in fact, they have the opposite effect because of the destabilization that I just described, but also because people who are arrested and detained experience overdose risk that's many times that of people who were not detained when they re-enter society. So we know that like the first 6 weeks after folks are released from detention, they are at up to 130 times more likely to die of an overdose than the general population. At the same time as these hyper-punitive measures in response to the rise of fentanyl are gathering steam, you have a conversation unfolding in the United States about other ways in which law enforcement is harmful to public health. There's this idea that public health or that law enforcement, policing specifically, is a public health crisis. There's a parallel discussion and discourse about defunding the police. And when we look at the metrics of police funding and funding for prisons and prosecutors, we actually do see that a disproportionate amount of resources at municipal, state, and federal level goes to various carceral expenses. So this includes law enforcement, prosecutors, prisons, and the courts. So we developed a carceral resource index that compares expenditures on carceral systems to health and supportive systems combined, and basically creates an algorithm to see where, you know, zero is essentially parity, where you're spending the same on carceral systems and health and supportive systems combined. And that's a very generous index, because like there's, you know, maybe you would spend the same on carceral and health and supportive, but even just taking those supportive and health in one bucket and carceral on the other, most American cities basically fail that low bar. So this this graphic depicts the level of funding of carceral, basically carceral spending overweighing health and supportive systems combined, where, you know, again, zero is parity. So most American cities are basically spending more on carceral systems than health and supportive systems combined. So in addition to the carceral system aggravating overdose through direct sort of relationships, such as fatal reentry and you know, acting across purposes to Good Samaritan policies and creating you know, a more toxic drug supply, it's also displacing or taking resources away from housing and other structural determinants of health that could help people you know, on the road to recovery and help to manage people's substance use, because most resources are actually being siphoned off by the criminal legal system. So I think that the sort of the, you know, the main takeaway point from this description of the overdose crisis and its trajectory and the moniker opioid epidemic is that really is a misdiagnosis. You know, the idea that opioids, you know, are the sort of the villain in the story. It's really important to understand that you know, the opioids are really just a symptom of broader structural dysfunction. And that structural dysfunction includes the fact that, you know, we're spending vast amounts of resources on carceral systems versus health and support combined, and other kinds of structural factors that are making people miserable and creating pain, both direct in its direct meaning, but also in a figurative sense, from economic, social, you know, sort of economic degradation, social isolation, and other kinds of factors that are driving the demand for opioids. So everything that has the U.S. has focused on has been focused on supply. Not much has focused on the demand. You know, why are people looking for you know, essentially an analgesic effect from these drugs? You know, this is something that is borne out by the data, because when we ask people, and this, you know, these data were collected back during the sort of the first wave of the epidemic, where you know, folks who are using prescription opioids non-medically, meaning using opioids in ways that were not prescribed to them, either they you know, are using them from a prescriber, but in ways that are not prescribed, or they're buying them on the illicit market. The vast majority of them are using them basically in self-treatment. They're using in physical to treat physical pain or emotional pain. So, you know, a lot of these other areas are areas of emotional well-being. It's also important to underscore, to kind of, you know, broaden the lens a little bit and think about the fact that, you know, it is not just opioids, because overdose rates in the United States have followed a kind of, you know, logarithmic progression since the 1980s. because even before opioids, with the rise in cocaine and other stimulants, there's been a general increase in folks dying of overdoses, and that kind of pattern has continued. So it really did not start in 2000 with the introduction of OxyContin, as the story has been told. And it is also important to, again, broaden the lens a little bit and look at the structural context of the fact that folks in the United States are dying of other causes at much higher rates than before. So this is a graph that was made popular by the disease of despair literature, where you see deaths involving suicide and alcohol-related causes have also been on the rise precipitously over the same time. So it can't just be opioids. As I've already mentioned, the disparities in deaths also are an indictment of structural factors like racism, because we've seen that our Native or First Nations in the Canadian context communities are at much higher risk of overdose deaths than other groups, and that is because of structural racism and the legacy of colonialism and other factors. So it's really important to see this in a broader perspective as well. And as I've already mentioned, as the crisis has morphed and kind of has shifted into the illicit market territory, with the rise in criminal legal responses, we saw an increase in disparities involving Black and brown folks dying of overdoses at higher rates, because the disparities in the way the criminal legal system is deployed also affects their health and access to substance use treatment and harm reduction. So to kind of wrap up with this discussion of the structural causes, it's really interesting to understand and kind of integrate the fact that in the United States, the people in the United States report much higher levels of pain and chronic pain than in other places. So if we think back to the graph that shows, the disparity between how Americans utilize prescription opioid analgesics, that's not just because of the sort of the commercial determinants of health, where the pharmaceutical industry is pushing these drugs, but it's because there's a lot of demand for analgesia. And this is reflected in this graph showing that people in the United States report the most pain levels of pure nations. So the kind of wrapping up here, thinking about this theme of commercial determinants of health, one of the problems with how the narrative around the opioid epidemic has been deployed isn't just that there's been a kind of misplaced blame and the idea that the criminal legal system continues to be the answer to the crisis, but it's also been the narrative around bad apples. And what I mean by that is this narrative has focused on sort of the bad guys, the villains being Purdue Pharma or specific pharmaceutical companies doing bad things, and kind of the DEA being the good guy running around trying to shut them down. Because the reality is that the pharmaceutical industry as a whole is deeply, deeply broken and requires wholesale reform, but the narrative around bad apples obscures that fact. In no place is that evident, as with the deployment of naloxone in the United States. Naloxone, as you all probably know, is the overdose antidote, highly effective, really cheap, drug, was developed a long time ago. And yet, it has shown major promise since the early days of the crisis. But the deployment of naloxone in the United States has been really, really highly limited by policy responses, by the sort of structural context, including its cost, intellectual property protections, and various legal sort of limitations with the deployment of naloxone. So it really wasn't until the last couple of years that population level naloxone access really finally became a reality, even though we've known since 2007, 2008 that it can save thousands of lives. And the reason why it's been limited is because of these structures that exist that we really haven't looked at, haven't addressed, because we've been focused on the narrative around Purdue Pharma and the bad guys. The similar story can be told about access to medications for opioid use disorder. As I've already talked about, access to medications for opioid use disorder, which have enormous potential to save lives and prevent overdose. Unfortunately, in the United States, we still have only 2 and counting naltrexone 3 options available. Obviously in Canada, thankfully, there are many more options available. But even the deployment of these drugs, methadone and buprenorphine, has been highly, highly limited. So this is kind of an illustration of the gaps in access to sort of cascade of care for people with opioid use disorder. Where the target is 90%, but we really only are serving about 10% of people who need these medications. At the same time, the sort of culture, a profit motive and the commercial determinants of health have made profit-driven rehab industry very, very active. And as you may know, a lot of these rehabs don't offer access to medications. A lot of it is non-evidence-based practices. And in the United States, there's pervasive consumer abuse basically through these kinds of rehab facilities. So it's really a public health disaster and also consumer protection disaster as well. One of the sort of most vivid illustrations in failure to provide access to medication for opioid disorder and the kind of the limited thinking about providing this access is the fact that in the United States, I don't know what the situation is in Canada, when you're part of the healthcare system and you have an opioid use disorder, in many places you're not allowed to access these medications. In other words, as a healthcare provider, you're out there telling people who have opioid use disorder about the benefits of medications and that the fact that they provide overdose prevention benefits, infectious disease benefits, just allow people to regain sort of stability and regain control of their health decisions. But you're out there prescribing these medications, but if you yourself develop an opioid use disorder, you're not allowed to access them. So you're mandated to enter abstinence-based treatment as a healthcare provider. And that's just, like one of the most paradoxical and absurd illustrations of just how broken the system is. On the harm reduction front, US again is much sort of is behind times in terms of what kind of services are available and the broader population access to these services. So even though certain service programs are available in some places, they're highly, highly limited, and access to them is very, very geographically. So the bottom line here is really that there's no easy fix to this crisis. And this is not necessarily a revelation for all of you, but I think is important to think about because in many policy and the policy discourse, a lot of times there is an assumption that there is an easy fix. So like if there's if the crisis is caused by contagion in painkillers, we need to shut down the painkiller supply and that'll fix it. Then there's a broad availability of heroin. We need to shut down drug trafficking organizations and that'll fix it. There's then when the crisis shifted to fentanyl, there was an assumption that attacking the fentanyl supply through a number of hyper-punitive measures was going to fix it. And of course it hasn't, and it just has continuously poured fuel on the fire because focusing on the supply obscures the fact that there's underlying demand for analgesia and for opioids and other psychoactive substances, and it has both literally and figuratively sucked up the resources and policy attention, and that's why the crisis has morphed from bad to worse. So kind of zooming out and some closing thoughts. Oftentimes we think of laws, and we actually use that language, policy, thinking about public health policy as like a population level remedy. This is going to be a remedy for a particular problem. And so, yes, laws can be used to improve health, and they're widely in that way. But the way that they're developed and the way that they're enforced, and the gap between what the law says and what actually happens on the ground, oftentimes limits the public health benefit of these laws. Just kind of like leaving you with this conceptualization of when we develop actual remedies, when we develop medicines, there's a concerted research process that is focused on finding that kind of therapeutic window, that perfect dosage, the perfect amount of medication. We conduct clinical trials to kind of understand where the limits are between not enough of a dose or maybe toxic dose, and where you're causing an overdose or other adverse events. So that process is deliberate, takes many years. There's a lot of research that goes into it, clinical trials, animal trials, and so forth. So developing remedies on an individual level has this concerted process. Developing remedies on a population level, when we think about developing policies to address certain problems, there's nothing like this. And so what we often have is policies that are either like in this area where there's not enough of a dose, it's not doing anything, or more often with drug policy, we're really in the toxic area. We're in the area where we're, literally, there's so much toxic law out there that's having all these negative adverse consequences, and there's not really a feedback loop to say, we need to change what we're doing. Thankfully, there's now conversations about decriminalization and different kinds of regulation here in Canada and throughout the world, but they really took a very long time. And in the meantime, we were really overdosing on bad drug policy. So, at least in the US context, and to some extent in the Canadian context, we're really in a situation where we know what works, and we're really not doing what works enough. And we're actually diverting our attention to things that sound good, that are an easy fix on sort of the theatrics, the optics, but are not actually working and not producing adverse consequences. And that we, one of the ways in which we can address this is by changing how we talk about issues and using more precise language, more nuanced language to describe problems than talking about an opioid epidemic, which kind of elicits these supply-oriented approaches. And just to wrap up, I think that what I've talked about focuses on the fact that there are multiple system failures that are driving demand for opioids and other illicit substances, and the crisis is really a symptom of those system failures, and not really a symptom. Not really about opioids at all. It's not really about the specific drugs. And that we really need to resist the impulse to only address the symptoms and not the root causes of the problem. And then finally, that Hollywoodization of the crisis and describing it in its simple terms has really done a disservice to our response to the crisis of kind of poured fuel on the fire, morphing the crisis from bad to worse. So thank you so much. Sorry, I went over a little bit, but there's still time for questions, which I'm really looking forward to the discussion.